A very good evening to one and all. I take this opportunity to invite Dr. Devi Prasad, who is Assistant Professor at IMS and SUM Hospital, Bhubaneswar. He'll be covering a very important non-invasive methodology, which is ONSD in the Neurocritical Care Unit. On behalf of Neurocritical Care Society of India and Classroom Series, we welcome you, sir. Over to you.
Good evening, everyone. Thank you, ma'am, for the kind introduction. Today we'll be delving deep into something which can be done very easily at the bedside, yet has a big contribution in seeing the prognosis as well as the treatment schedules. So, to start with, I have no conflict of interest to share, and we'll be going on in these headings: anatomy and physiology, how to do it. We'll do it in a small video. We'll recap of the review of the current evidence and a special light on the pediatric ONSD. What are the pitfalls or the limitations of these things, and what are the take home points? So, as usual, beginning with anatomy. So, this image, everybody is well versed with this. So, the intraorbital portion of the optic nerve, uh, developmentally or ontogenically, is a part of the central nervous system, and it extends from the ocular bulb to the optic canal and is surrounded by the cerebrospinal fluid and optic nerve sheath. This optic nerve sheath is a membrane made up of leptomeninges in continuity with the dura mater of the brain. Now, the perioptic subarachnoid space is prolongation of this intracranial subarachnoid space, and specifically, it is the chiasmal system which is in continuity. And just because this optic nerve is surrounded by the CSF, which is connected to the ventricular system of the brain, and hence it borders a small amount of brain of CSF in subarachnoid space, and any increase in ICP is therefore believed to cause a transmission of forces through these spaces, resulting in distension of the ONSD. Uh, Notably, further support for this theory is suggested in studies in which there has been a reverse correlation, in which, in cases where there is a decrease in the ICP, let's say after a lumbar puncture, there has been a linear decrease in the value of the optic nerve sheath diameter. As the optic nerve sheath diameter is distensible, these changes rapidly with changing cerebrospinal fluid pressure, and when this ICP rises, maximum optic nerve sheath degenerations happen in the anterior subarachnoid component, which is basically 3 millimeters behind the globe rather than the posterior perineal line. So this is what is our optic nerve sheath. The circular thing is the optic nerve, which is in turn, it is surrounded by three layers like the pia mater, the arachnoid mater, and the dura mater, which in a cross section looks somewhat like this. Uh, the orange thing which you see is the optic nerve, the pia mater in close proximity to it. The cobweb steps which you are seeing are basically the arachnoid matter, and the dura mater is the one which is surrounding it. Now, along with this, there are other things called as arachnoid trabeculi. What this arachnoid trabeculi has a clinical significance is uh, these changes which happen in the optic nerve sheath diameter basically is non-uniform. Meaning to say, the sheath changes which happen in the area of the lamina cribrosa and in downstream are different. This is due to the difference in the arachnoid granulations which are present over here, and by far it has been known, and it has been proved beyond any doubt that it is 3 millimeters down this lamina cribrosa is the area where the maximum changes in the optic nerve sheath diameter happens. So we will be going to a video in the subsequent slide, and for that what we have to do is we might have a patient who might be totally conscious awake. In that case, we have to explain the patient about what we are going to do, or if the patient is obtunded, then the counseling part might not be necessary. And for that, what we have to do is we have to close the eyes and cover it with a sterile transparent dressing, something like a tegaderm, and take copious amount of gel and then insonate the orbit. And for that, we have to use a linear high frequency probe, anything more than 7.5 megahertz. And this is a schematic which we can see on the right side of the screen. So there is a point which we denote as D1, that is the furthermost point of the retina, which is known as the lamina cribrosa. We have to take this point as the first landmark and drop a longitudinal line which measures 3 millimeters. And from this 3 millimeters, we have to drop another line which is perpendicular to the first line and measure this sheath. For this, this is another schematic which shows the optic nerve, the subarachnoid space, and the optic nerve sheath. Now, what we are going to do is we'll be seeing a small video. For this, what we have to do is first, for optic nerve sheath diameter measurement, the examiner usually stands at the head end of the patient, and before insonating this, what we have to do is we have to follow the principle of ELARA, which is used in radio diagnosis, is as low as reasonably achievable. For that, we have to decrease the MI, mechanical index, and the tissue index as low as possible in order to prevent the radiation or the ultrasound induced changes or detrimental changes which can happen to the sensitive structures like the cornea or lens. And in lens, lenticular opacifications are very common. So as low as regionally achievable, and then we start insonating. So we bring it to a minimum, which differs from every equipment to equipment. And after that, we have to select the frequency, which I have selected as 10 megahertz, and then time gain compensation we have to see for we to ensure so as to get a perfect image. The right, the patient literally lies supine. We have covered only one half of the eyes because this is for demonstration purposes only. So we explain the patient and we tell the patient to look up and insonate from the temporal side of the eye. uh, we have to be very careful not to put undue pressure on the eyeball, because that can have two manifestations. First, it can increase the pressure of the intraocular pressure, and hence we can get a false reading. And in patients who might be borderline status in glaucoma patients, there we can precipitate a crisis. So in that case, what we have to do, a better way of doing it is to put the percussion side of your dorsum of your hand over the orbits, and then we can insonate. And so the further part which we can see over here is the anterior chamber. This is the cornea, this is the lens, this is the posterior chamber in which the vitreous chamber is there, this is our retina, and this is the lamina cribrosa, this is the optic nerve. Now with minor adjustments, what we have, one second, with minor adjustments, what we have to do is we have to bring the optic nerve in line and in longitudinal to the axis, where we can see a hypoechoic structure in the midline, which refers to a optic nerve, then a hyperechoic structure adjacent to it, which is the optic nerve sheath, and then the overall covering of the orbit. So what we are doing is we have kept a pointer at the lamina cribrosa, and we have dropped a perpendicular, and the length is 0.3 centimeter, which is equivalent to that of 3 millimeters. And from this point, we drop another line perpendicular to this line to intersect at these 2 points. So I'm taking a second point. The point we have to be very careful is we have to measure the sheath and not the total distance, the total hypoechoic structure. I'll tell you in subsequent slides as to what that means. So this is a nerve sheath, and here our sheath comes, diameter comes as 0.46, which is fairly normal. After that, one word of caution is this hypoechoic structure can also be confused with a retinal artery, which may be there in majority of the cases, and that diameter might cause differences, and erroneous ONSD values can be obtained, and hence the thing to go about is we have to put color Doppler in that, and then we have to see whether the echoic structure is limited only by the artery or it's the nerve. So we can get a Doppler here, which tells us that it is the artery, which occupies a minor fraction, and the total fraction is in fact by the nerve. So these are the probe positions, and this is one occasion when we had actually 0.64. This is a raised ICP feature. Now, there are variations in which different, because the procedure is not standardized, so there are different methods in which, in various studies, you'll find different ways to go about. Like in some studies, it has been shown that like we discussed, this is the optic nerve, this is the sheath, and dura mater. So, majority of the studies have, in fact, measured this as the optic nerve sheath. Whereas in some studies, if you just move your probe a little bit, this is what you will get to see. And here, the optic in the same patient, the optic nerve sheath appears like this. This is where we have to be very careful, because actually we have to get the hypoechoic followed by the hyperechoic and then hypoechoic. These three things have to be in tandem to, and this is the place where we have to measure it. If we end up measuring here, we'll get an erroneously high optic nerve sheath diameter. Once this is done, the another thing is where to measure or where to drop the 0.3 centimeter mark from. So this is one part, this is another part, this is third part. These 3 points have been dealt in different studies. This is the part which is the fovea centralis. This is the part of the retina. This is the this is the place where the optic nerve enters the retina, and this is the lamina cribrosa. So basically, we have to take a measurement from point 3. So where you see the hypoechoic structure merging with the hyperechoic structure, that is the place where you have to drop a zero point 0.3 centimeter line, and then you have to take. And this is a study where they have seen, this is by Stevens et al., in which they have seen assessment by neuroanesthesiology, a review of the methodological discrepancies, and based on their observations, they found quite a bit of heterogeneity in the points in which they have taken the measurements, like we discussed. Now we go to a review of the evidence and clinical applications. So this dates back to 1780, in which the presence of meninges around the optic nerve had been documented by Zinn, but it was not before 1968 by the great Sohan Singh Sahere, in which he showed that a rise in cerebral spinal fluid pressure in the cranial subarachnoid space and its successful transmission into the sheath of the optic nerve with a rise of pressure in the latter was found to be essential for the production of edema of the optic disc. Now, this was a path-breaking finding which was published, after which the work on optic nerve sheath diameter as a surrogate marker of raised ICP came up. And there was a great bit of studies going on, and we will go to the individual clinical applications along, and side by side we will be seeing the evidence as well. So first, starting with intracranial hemorrhage and ischemic stroke. So this was a study by Naldi et al. In which they report a sensitivity and specificity of 100% for optic nerve sheath diameter for the detection of increased ICP. They compared with the Doppler indices, and they took 25 odd patients with ICH, and they compared and did a validity study along with the clinical and the radiological CT scans of raised ICP, and they found a sensitivity and a specificity of 100%. Next, this one was by Sklodorix et al., in which in 2011 they found out that the distal enlargement of the optic nerve sheath in the hyperacute stages of intracerebral hemorrhage. And they found out that the best cutoff point to predict the intracranial hemorrhage in volume excess of 2.5 mLs is uh, somewhat a diameter more than 0.66 centimeter with a 90.3% accuracy and inter-rater reliability of zero point 0.7. So the next was by Yesilras, in which the diagnostic and prognostic value of the optic nerve sheath diameter on CT for diagnosis of spontaneous subarachnoid hemorrhage was done, and they in this study found out a threshold value of 6.1 with a sensitivity and specificity of around 72%. Now, another was by Border et al., in which, in again in aneurysmal subarachnoid hemorrhage, but another point of interest which they pointed out in this paper was uh, the increase, the time lag of the optic nerve sheath diameter to increase following a aneurysmal subarachnoid hemorrhage was intact, was very low, but even after the raised intracranial pressure subsided, yet it took a fair amount of time for it to come back to the normal state, and the nerve sheath diameter remained expanded even after the normalization of ICP. They gave a hypothesis that it might be likely due to an impaired retraction capability of the optic nerve sheath, and this finding should be taken into consideration when using transorbital sonography in the neuromonitoring of aneurysmal SH. And another one was by Goxin et al., in which there was alterations in optic nerve sheath diameter according to cerebrovascular disease subgroups, and they found out that in early cases of cerebrovascular disease, the mortality and morbidity can be decreased through the early diagnosis of the possible existence of ICP increase according to the ONSD levels. Then another by Joe et al., in which, in addition to optic nerve sheath diameter, they added another parameter which is known as the optic nerve sheath diameter to the eyeball transverse ratio. Now, this what they did was this eyeball transverse diameter ratio was done or taken from a CT scan. It was not taken from a optic nerve sheath by a sonographically method. It was taken from a CT, and they found out that in acute stroke patient with massive cerebral infarction, an increased optic nerve sheath diameter or a diameter um, to the eyeball transfer diameter ratio increases the odds of malignant progression and may be used as an indicator for emerging therapeutic interventions. In addition, the optic nerve sheath diameter to ETD ratio may be more valuable than ONSD in predicting the malignant progression of acute stroke patients. This was an observational study in which they found out the prognostic values of ONSD for comatose patient with acute stroke, and they saw that the mortality increased in comatose patients with acute stroke when the ONSD was more than 5.7 or the ONSD to ETD ratio was in excess of 0.25. And they concluded that both the indices could be used as prognostic tools for comatose patients with acute stroke. Uh, as far as the comparison between the individual parameters is concerned, the ONSD to ET2 ratio was more stable than ONSD alone, which would be preferred in clinical practice. Next, coming to idiopathic intracranial hypertension. Now, idiopathic intracranial hypertension, also known as the primary pseudotumor cerebri syndrome, it refers to a disorders in which the mechanism of a raised ICP remains elusive, where there is an increase in ICP without neuroradiological abnormalities. So in this, what Chen et al. Did was they did an ultrasonic measurement of optic nerve shape diameter, and they used it as a non-invasive surrogate marker for dynamic and real-time evaluation. And what they found out that this ultrasonic measurement of ONSD can reflect the relative real-time changes in ICP. Now, another one by Lochner et al., in which he assesses the feasibility and usefulness of ultrasonography in idiopathic intracranial hypertension. And they found out that increased ONSD values detected by TOS support the diagnosis of intracranial hypertension. And the optic nerve sheath diameter measured sonographically as a non-invasive estimator of intracranial pressure. This was a systematic review and meta-analysis by Shararova and Yusuf Gitero. And as we can see, the sensitivity and the specificity is fairly high. And although the wide 95% confidence interval in the pool data, that has to be the findings has to be taken with caution. Yet they could prove that ultrasonographic ONST might be a potentially useful approach for assessing intracranial hypertension when the invasive intracranial devices are not indicated or not available, as in a resource limited settings. And the role of optic nerve sheath in increased intracranial pressure. This was a systemic review and meta-analysis, and this is by David Banaho et al. And they found out that it is a fast and cost-effective method with a high diagnostic accuracy. And they suggest a cutoff as usual. It has been known that it has not been successfully established, but they suggested a range of 5.6 to 6.3 millimeter range as the best for the diagnosis of intracranial ICP increase. Then something called as the intracranial hypotension or the patch test. So this is something called as a dynamic measurement, in which this is done at 2 time points at 2 different positions, and this has been proven useful in patients affected by a spontaneous intracranial hypotension. And the first measurement should be conducted starting with the patient in supine position and then in upright position with the patient standing for 2 minutes. Another possibility, this can be done to after in addition to the fact that it can give a diagnosis of in hypotension. It can also is the measurement of optic nerve sheath diameter can be done approximately 5 minutes prior to the lumbar puncture and 5 minutes after a lumbar puncture, in order to estimate the real time reduction in CSF pressures or the efficacy of a epidural blood patch. In cases of a postdural puncture headache, if at all epidural blood patch procedure is being done, then this dynamic measurement can be done prior to the epidural blood patch and after it, so that we can see. And studies have shown that with this technique, the optic nerve sheath diameter has increased post the successful institution of a epidural blood patch. Another one was this is a study in which they have shown that they included 10 subjects, and they took at 10 minutes before, 10 minutes after that, 2 hours after blood patch, and 20 hours after epidural blood patch. And they were seen that epidural blood patch was followed by ONSD enlargement in subjects with successful EBP, but not in the subject with EBP failure. Since ONSD is a surrogate marker of ICP, this suggests that a sustained increase in ICP is associated with a successful EBP. Then posterior reversible encephalopathy syndrome. Now, this is a clinical and radiological syndrome consisting of headache, visual disturbances, seizures, and imaging findings, including cerebral edema affecting the cerebral cortex and underlying white matter, and the pathophysiology involving the impairment of cerebral autoregulation, resulting in arterial hypertension above the limit of the cerebral self-regulation. There is a breakdown of blood-brain barrier and subsequent cerebral edema. So associated with either increase in ICP or altered blood-brain barrier permeability. In this context, TOS may be useful in demonstrating papedema and an increase in size of the ONSD. So Lochner et al. Yet again did a usefulness study in which they analyzed the use of ultrasonography in posterior reversible encephalopathy syndrome, and they found out that the ONS showed changes of optic nerve sheath diameter and optic disc elevation, which correlated with clinical improvement, and they also validated with TCCCAs. Then coming to meningitis and encephalitis, this was a study by Nabita et al. In Uganda, in which the accuracy of non-invasive intraocular pressure or optic nerve sheath diameter measurements for predicting elevated intracranial pressure in cryptococcal meningitis was done. And in this, non-invasive intraocular pressure measurements were done both by ultrasound and then corroborated with tonometry, and both of these correlated with the cerebrospinal fluid opening pressure, but both are a suboptimal replacement for an actual ICP measurement with a manometer. And this was by Sangani from an Indian study. This can sonographic measurement of the optic nerve sheath diameter be used to detect raised intracranial pressure in patients with tuberculous meningitis. This was the observational studies in which they found out that compared with 120 control patients, 120 tuberculous meningitis patients, the upper limit of normal optic nerve sheath diameter was somewhere around 4.37 in the control group, whereas those with tuberculous meningitis had a mean of 5.81. And these results confirm that the patients with tuberculous meningitis have an ONSD in excess of the control data. And the evaluation of ONSD is a simple and non-invasive, potentially useful tool in the assessment of adults suspecting of having TBME. Now, all these and things which we are discussing and which is under all the evidence which you have got basically point out to one single thing, is that in addition to the an absolute value of ONSD, it is the serial measurements or the trends of the ONSD which is more important than the absolute value. Absolute value is important, yes, it will give you a value whether it to begin with, whether you have a situation of raised ICP or not, but you have to follow the trends as well. And it has been found out that there is a linear increase in the diameter of the optic nerve sheath till value of 7.3 millimeter is found, and after that it plateaus off. So we have to be very careful while seeing all these parameters. Then coming to acute mountain sickness, in acute mountain sickness, hypoxia may increase the cerebral arterial blood flow, and hence venous volume may increase, leading to the increased ICP. And this was a study by Fagenholz et al. In which they found out that mean optic nerve sheath diameter was 5.34. In the 69 subjects with acute mountain sickness, they performed serial examinations in 284 subjects who traveled at high altitude to Feriche Pass in Nepal. And in these subjects, they used a by using a quantification score known as a Lake Lewis score, and which had a strong positive correlation with the change in ONSD. And in the other subjects, they had a mean of 4.46 millimeter, which is fairly normal. Now, in hydrocephalus, this was a study by Lee et al. And they concluded that ONSD measured on preoperative brain CT was linearly correlated with ICP in adult patients with communicating and non-communicating hydrocephalus, and it was a predictor of increased ICP with good discrimination and high inter-observer reliability. And this was another study by Newman et al., in which they concluded that the evaluation of the ONSD is a simple and non-invasive method, which is potentially useful tool in the assessment and monitoring of children with hydrocephalus suspected of having raised intracranial pressure. We'll delve deep with the pediatric ONSD in the subsequent slides. And this came in the European Journal of Neurology by Earlt et al., in which they measured changes in the ONSD in patients with idiopathic normal pressure hydrocephalus, which they did a mean pre-puncture ONSD values and a post-puncture values, and they concluded that the ONSD values before and after spinal test correlated well with the clinical effects of the CSF removal, and transorbital sonography seemed to be a reliable and a safe add-on to the Fisher test and may support selection of patients for shunt intervention. So a patient in which a puncture was done, and we could see a significant decrease in the ONSD values, those patients fared well when a definitive shunt was done in those patients. So now we'll come up to the neurological complications in some non-neurological settings. So starting with pregnancy, pregnancy is associated as usual with pathophysiologic changes which predispose to several neurological disorders, and such studies report that ONSD can predict the development of preeclampsia and eclampsia. This came in anesthesiology by Dobo et al., in which the optic nerve sheath diameter was used as an ultrasonographic assessment of the incidence of raised intracranial pressure in preeclampsia, and they found out that uh, they may offer a practical means of monitoring intracranial pressure trends. And in about 20% of the preeclamptic patients, ONSD reaches values compatible with the intracranial pressure above 20 millimeters of mercury. And this again came in the International Journal of Obstetric Anesthesia by Simek et al., in which they included 30 patients with severe preeclampsia and 30 controls, and they found out that ONSD was significantly higher in patients with severe preeclampsia compared to controls before delivery and 1 day and 4 days post delivery. Similarly, the optic disc height was significantly greater in patients with severe preeclampsia, and they concluded that severe preeclampsia was associated with a significantly higher ONST and increased optic disc height, which could be the ultrasonographic evidence of papilledema. Now, coming to cardiac arrest, now few parameters have been used to predict the neurological outcome of post-cardiac patients. In early stage of treatment, optic nerve sheath diameter measurement is valuable as a prognostic indicator of hypoxic encephalopathy, both on CT as well as ultrasound with contrast. But the better prognostic value was observed when ONSD was combined with other parameters such as gray to white matter ratio on initial CT in post cardiac arrest subjects. So this came in resuscitation, and this was done by Shelley et al., and in which in two French ICUs, a prospective study included all consecutive patients with cardiac arrest without traumatic or neurological etiology and successfully resuscitated, and ONST measurements were performed on day 1, day 2, and day 3 after return of spontaneous circulations. And they concluded that ONST ultrasonographic measurements within the first 24 hours after cardiac arrest is a promising way to evaluate the severity of post-CA brain injuries and outcome in a multimodal neuroprognostication approach. And this is simple, cheap, available for serial measurements, and correlated to brain edema, neuron-specific anoles, axonal markers, CPC score, and survival. And then in post-cardiac patients done by Yuda et al., there was a sonographic study in which they try to assess the neurological prognosis after cardiac arrest, and the mean ONST associated with favorable prognosis was somewhere around 5 millimeters, and the poor prognosis was there when the reading went beyond 6.1. So they concluded that optic nerve sheath diameter less than or equal to 5.4 millimeters was an indicator of a favorable prognosis, with a sensitivity of 83% and a specificity of 73%. This was a transorbital sonography for early prognostication of hypoxic ischemic encephalopathy after cardiac arrest, and this was done by Ert et al. And the total of 15 patients had a good outcome in comparison to the 49 patients initially unconscious with a GCS of less than 6. And they concluded that the early and reliable prognostication of outcomes in patients with HIE can be simplified by ONST values gathered with the use of TOS, and main advantages compared with other established markers are prognostication within the first 24 hours and independence from therapy from with hypothermia, and a higher level of accuracy can be reached by combining computed tomography gray to white matter ratio values and optic nerve sheath diameter values. Way in which the optic nerve sheath diameter values gives us a better and better yeah, than a CT scan is. For a CT scan, though it gives you a better value of or a better indicator of a ICP, yet you have to shift the patient who are mainly critically ill, will be on ventilator, on multiple medications and infusions. You have to shift them from the ICUs to the imaging suites, and then you have to come back. So in these cases, a serial estimation of optic nerve sheath diameter, which in fact gives you a ICP, is a better way, and it's a better non-invasive way than going for a routine CT scans. Then we come to the pneumoperitoneum. This was a systematic review and meta-analysis in which they used the optic nerve shear diameter for predicting elevated intracranial pressures during laparoscopic surgeries, and they usually used in the early period and in the late period. Early period meaning less than 30 minutes, and late period less than beyond 30 minutes. And they revealed that the ICP elevation during laparoscopy could be anticipated through a significant increase in ONSD in the early and the late periods during CO2 pneumoperitoneum. Now coming to ONS in pediatrics, this came in pediatric neurology, in where they compare B scan ultrasound and MRI based optic nerve sheath diameter in children, and 150 children diagnosed with either tumor, hydrocephalus, or other intracranial pathologies were included, and bilateral ONSD was quantified by using a 12 megahertz linear array transducer, and this was compared with ONSD measured in simultaneously acquired T2 weighted MRI scans of the orbit. And they conducted repeatability studies for watching the intra-observer variations, and the overall mean values of ONSD were around 5.8 and 5.7 for US and MRI respectively, and the correlation between the ultrasound and the MRI based ONSD was strong, and repeatability and reliability of this ONSD determination is excellent, and in case of ultrasound guided assessment is not possible or available, MRI scans can serve as an excellent alternative. The difference of US and MRI ONSD is minimal and insignificant, and hence both techniques can be complement each other. This was by Canada et al., in which they used as a non-invasive approach to evaluate the increased intracranial pressure in critically ill pediatric patients, in which they included patients who were neonates and in adolescent as well. So this is the table showing the pediatric population, in which the age group has, and the different authors have done a different age group analysis, in which they found out the normal mean optic nerve shear diameter and a cutoff value pertaining to these ages, where a value more than this value can be termed as an intracranial raised ICP value. So basically, everywhere anything beyond 4 in children from 0 to 2 years of age is significant. Continuing with that, so this was elder age group, in which they found out diameter of more than 6, and this had a value of more than 5.8. Then it can taken into account the neonates. This was in 0 to 2 months, in which this again more than 4 is taken as the cutoff value. Now, what are the pitfalls or limitations? So the main limitation is a lateral resolution is around 0.3 to 0.4 millimeter. This is a serious impediment which we have to take into account. It is very difficult to perform in patients who have ocular trauma, in patients who have glaucoma, in previous optic atrophy, and there are inherent variability in optic nerve sheath from person to person, and that things has also to be taken into account. There is lack of standardization, both in case of as the how it is done, what methods have been applied, what ultrasonography points have taken into account to measure those values, what is the absolute values, what are the cutoff values, as well as the trends. So standardization is lacking. Various authors have given various description, you can find it in the literature, and uh, apart from that, there is also even if you do it in one particular way, there is an intra observer variation as well. So every time you measure, that might be changing from one measurement to another measurement, and so this has to be taken into account. Future perspectives So first, pre-hospital settings. There have been a couple of studies in which they have used in pre-hospital settings. One was ambulance-based study, and another was a helicopter-based study in Sweden, and in which they have seen demonstrated the feasibility of this technique. The subset of patient which were, have taken was brain trauma injuries. Traumatic brain injury, but however, logistic issues remain the most important deterrent in this condition, and hence there are two or three studies ongoing on this aspect. And the next is the all talked about AI, artificial intelligence. So another field of research could be the development of automated computerized systems for the segmentation of structures in beam mode ultrasonography, and that may help to reduce the operator dependency, accelerate the acquisition time, and mitigate the issue of interoperator and intraoperator variability. Now, for this purpose, various algorithms, neural network analysis are currently under investigation to integrate these artificial intelligence in automated ANST acquisition. And on these, this was a very recent study in August 2023, in which or the authors by Moore et al. They evaluated six commercially available point of care ultrasound devices for automated optic nerve sheet measurements. So what they did was, each of these six devices they took into account, and they hired novices, persons who are very beginners to that of very beginners to ultrasonography. They were given, and those automated measurements were taken, and in those same patients they started with mannequins, and the same was taken over to patient population. And in those patients they saw what was the difference in the automated results found out by these devices, and in comparison to that followed by experienced physicians. And they found out that these are the different methods which were found out, and the overall utility, like they quantified wide with a score in which one was the best and six was the worst. And with some of the devices, they found out quite a good overall utility for ONSD, and in terms of the image quality, the acquisition ease, the software, and the tactile feel. So the take home points: this is a viable alternative for a non-invasive continuous estimation of ICP. Absolute cutoff values have been poorly defined, and it is the trend of the values which are more significant clinically. And standardization of technique required for reducing intra and inter-observer variability. Uh, Optic nerve sheath diameter combined with other clinical and diagnostic parameters has better accuracy rather than ONST alone. Thank you.
Thank you, Dr. Devi Prasad, for that extensive and really well covered talk on all aspects of ONST.
Thank you,
So,
ma'am.
in your practice, how frequently do you monitor ONST for a patient who's come with features of raised ICP?
Post the initial resuscitation phase, usually we it's our practice to put a ultrasound probe on the orbit to see what is the ICP, so that because we have to keep in, we will be going on with the resuscitation, anti-edema measures will be given. In some patients, AVD will be being placed and all. So we usually it takes very less time. In experience had, it takes less than a minute to find out, and we take one reading, and three readings are taken, and average is taken in one eye, and the average is the same is repeated on the other eye, and the total process takes less than 2 minutes. So in that case, we always keep a pre and a post intervention thing, and in all our ICU patients we usually follow it up. And in cases where the optic nerve sheath jumps and there is a little bit of change in sensorium, in those cases, those are the candidates we usually proactively send for a CT scan to find out actually what is going on. There's something wrong with the patient. It's not that it's not in isolation, because you have a clinical decline. Along with that, you have a objective increase in the optic nerve sheath diameter.
Yeah, correct. So, it is could be like part of a multimodal monitoring which will help take
Yes,
quick
ma'am.
decisions. So, with
Yes,
this
ma'am.
remark, On behalf of NCSI, I would like to thank you for giving this fantastic talk. Looking forward to
Thank you.
inviting you in more forums. Thank you very much.
Thank you.